Hi everyone, in this video we'll be discussing anti-TB drugs. Why tuberculosis is most important? Because we have so many cases of tuberculosis in India. We are considered the TB capital of the world. So many cases are there. And the problem in treating TB is the treatment requires very long period of treatment. So it is minimum of 6 months. Why the treatment is for very long period? Number one, the bacteria are in different phase. Some are slow multiplying, some are fast multiplying, some are not at all multiplying, that is dormant. And the next problem is resistance. If you don't completely eradicate them or completely cure the patient, the bacteria will become resistant. So that's the reason the treatment is prolonged duration. And nowadays we are facing the resistant issue. We have multi-drug resistant TB and extensive drug resistant TB, and very difficult to treat those TB. And those TB treatment will go for around 12 months to 1 year, 2 years like that. So that's the reason why TB treatment is very important and why the questions come from the exam. So let us start our journey of anti-TB drugs. I will take a small case. 51-year-old female came to the hospital with a 4-week history of cough and fever. Usually tuberculosis presents with that. Chest radiograph showed right upper lobe cavity infiltrate, and culture of the sputum. That is the most common investigation. We do the culture sputum. Culture of the sputum yielded acid-fast Mycobacterium tuberculosis susceptible to all antimicrobial drugs. So it is sensitive to all the drugs. Very good. So what are the drugs we use to treat tuberculosis? So let us start our journey. Anti-TB drugs, and you know the importance why we should know this. Very common, and it affects almost all the organs in the body. So moving on to the drugs for tuberculosis, let us start the anti-TB drugs. Anti-TB drugs. These anti-TB drugs can be divided into mainly two things: the first line drugs and second line drugs. Now, why it is called first line drug? The meaning of first line drug is they are the drug which are used in the beginning. So starting only we use them. The second line drugs are reserved for resistant cases. So usually first line drugs are the best one to treat tuberculosis. We use them in the beginning only. If they are resistant to these drugs, then only we go for second line drugs. That's why we have these second line drugs. In first line we have 4 important drugs that is called HRZD. H stands for isoniazid, R for rifampicin, Z for pyrazinamide, E for ethambutol. There is one more drug, S for streptomycin. It is considered as first line supplementary drug. It is considered as first line supplementary drug. So it is not used routine because it's an injection, and in some special cases only we use it. Otherwise, most of the drug sensitive tuberculosis we use the first 4 drugs HRZD. Now let us understand one by one what are the specialties of these drugs, and then we'll understand the second line drugs. Most of your exam questions is from the first line drug. So the first one is called H. What is that H meaning? The meaning of that is isoniazid. So what is the full form of isoniazid? It is called iso-nicotinic acid hydroside. So it is called as iso-nicotinic acid hydroside, or it is also written in short form INH. So it is also written in the short form as INH. INH stands for iso-nicotinic acid hydroside. The basic question is, how does it work? What is the mechanism of action? Let us understand that. What is the mechanism of action of isoniazid? Now let me give the simple mechanism of action. It inhibits mycolic acid synthesis. It inhibits mycolic acid synthesis, which is very important in making the cell wall of the tuberculosis bacilli. So when you inhibit that, the cell wall is not formed, so it inhibits cell wall synthesis, and if the cell wall is defective, that will lead to sidal effect. So the drug is tuberculocidal drug. So that is the mechanism of action of isoniazid in brief. Now if I want to go in detail about mechanism of action, let us understand that. in detail. Let us understand. Now INH, also called as isoniazid, is basically a prodrug. Now when we give the drug to the patient, the drug has to go to the bacteria and kill it. So let me draw a line here. So isoniazid will enter the bacteria. So this, what I am writing inside, is what is happening in the bacteria. So what happens in the bacteria? Isoniazid is a prodrug, it should be made active. So it will become the active form. So this is the active form. Now who will do that? There is an enzyme in the bacteria and the name is called catalase peroxidase. Catalase peroxidase is the enzyme which will make it active. Now this active form will form complex with two important molecules. What are the two important molecules? Number one, there is something called NADP+. So it will form a complex with NADP+, and that will inhibit an enzyme called dihydrofolate reductase. Dihydrofolate reductase. So when you inhibit the dihydrofolate reductase, that will inhibit the DNA synthesis. This is additional mechanism of action. So this is not being asked till now. So this is one of the other mechanism proposed. Now another mechanism that is proposed is this complex will bind to NAD, and when it binds to NAD, it has two important actions. It inhibits two important enzymes. What is that? The enzyme name is called acyl. It is called acyl carrier protein reductase. Acyl carrier protein reductase. And one more is called, it inhibits beta keto acyl ACP synthase. Now the question is, should we remember this enzyme so much? No need. No need for exam. It's just for your detailed review. That's it. So this will inhibit the enzyme. If you inhibit these enzymes are required for synthesis of an acid called mycolic acid. So if you inhibit these enzymes, what happens? There is inhibition of mycolic acid synthesis. Mycolic acid synthesis. So if you inhibit mycolic acid synthesis, what happens? There is inhibition of cell wall synthesis. Cell wall synthesis. And that is responsible for the cidal effect of isoniazid. Cidal effect of isoniazid. Okay, so this is in detail. Now these enzymes are coded by certain genes. So this is coded by a gene called INHA gene. We also call it as INHA protein. So the INHA gene which codes that is called INHA protein, and this is coded by a gene called Cas gene, and we call it as Cas protein. So this Cas gene and INHA gene are responsible for that. Which gene is responsible for catalase peroxidase? There is a gene called CatG gene. CatG gene. This is the one. Now, when we are using isoniazid, yes, it will act very good, very beautiful drug. But the problem is the bacteria is also intelligent. What does it do? It will mutate the gene. So what happens if this mutated gene is there? Then the enzyme is not produced. Catalase peroxidase is not produced. If it is not produced, even the INH enters inside, it will not become active. If it doesn't become active, it will not work. So that's the reason why isoniazid resistance occurs, because of the major mutation. What is the major mutation? It's the CatG gene mutation. If this undergoes mutation, the enzyme is not produced. If the enzyme is not produced, you will not get the active form and the drug will not work. And that is the mechanism of drug resistance, INH resistance. Another important thing is, again, this will also get mutated. So here, CasG gene can also undergo gene mutation. But this is not a major mutation, this is a minor mutation. So if it is mutated, again the enzyme is not synthesized, or it will not allow the NAD to bind to that. So again, resistance problem. For INHA will produce resistance because of overexpression. So the gene will express more. So if it expresses more, what happens? More enzymes are synthesized. If more enzymes are synthesized, then INH cannot inhibit that. Then what to do? You have to give the high dose of INH to overcome this resistance. So I'll repeat again. INH gene will overexpress the genes. So what happens? These enzymes are more. If these enzymes are more, the INH with the normal dose cannot inhibit. So what should I do? To overcome this resistance, I have to give high dose of isoniazid acid. That can be done. So these are the gene mutations. Remember, this is also a minor mutation. Okay, so we understood this aspect in detail. INH, what exactly acts with this. But basically, if you don't want that much, remember, it inhibits mycolic acid synthesis, inhibits cell wall synthesis. It is tuberculocidal drug. Very good. Now, once I understand the mechanism of action, it's important we understand the pharmacokinetics of the drug, PK. Now, when we studied pharmacokinetics, I told you the drugs undergoing acetylation, SHIP drugs. In the SHIP drug, I is isoniazid. Now, acetylation can be two ways, because acetylation is what? It's a enzyme reaction. Enzymes are what? Protein. Proteins are what? From genes. So, they can be slow acetylators in the body. They acetylate very slowly the drug, or there may be fast acetylators. So this is the pharmacogenetic condition. Now in India, 60% of population are slow acetylators, so majority are slow acetylators, and 40% are fast acetylators in India. So what is the problem if that is slow acetylators? So if they are slow acetylators, the drug is not metabolized faster, so the half-life in them will be around 3 hours. But in fast acetylators, the drug is metabolized faster, the half-life of the drug will be 1 hour. So that is the difference, a pharmacogenetic condition. So another important thing is, drugs undergoing acetylation, they can also produce something called drug-induced lupus. But drug-induced lupus is major problem with an antiarrhythmic called procainamide and an antihypertensive called hydralazine. Yes. So there is a risk of DLE, drug-induced lupus erythematosus. Another thing what we learned about isoniazid, if you remember the general pharma, we told that these drugs are enzyme inhibitors. So this is mainly an enzyme inhibitor. So it inhibits the enzyme cytochrome 3A 4-5. But there is also one more point you need to understand. It is an enzyme inducer. Which enzyme? It is an inducer of cytochrome 2E1. So it's an inducer of cytochrome 2E1. But majority of the point is to remember it's majorly an enzyme inhibitor. Remember, isoniazid is mainly an inhibitor, but only one enzyme it's inducer, that is cytochrome 2E1. Now since it is an inducer of this enzyme, it generates toxic metabolite, and that toxic metabolite will cause hepatotoxicity. So that is responsible for hepatotoxic potential of isoniazid. So the cytochrome 2E1 is responsible for that. Okay, so we understood the specialty of pharmacokinetics. It undergoes acetylation. It is mainly enzyme inhibitor. Only in case of cytochrome 2E1, it's an inducer. Sir, where do you use it? Yes, we use it in mainly tuberculosis. It is mainly used for tuberculosis as well as prophylaxis of TB. Sir, what do you mean by prophylaxis of TB? Suppose there are 4 people living in a room and one got TB. So they cannot live outside. So there is a risk they can also get TB. Or a mother has TB, child doesn't want to have. So that time the best drug is isoniazid. Isoniazid is also used in Mycobacterium carnosine. Sir, can we use it in other bacterial infection? No, because other bacterial infection, they don't have mycolic acid. Only this TB has mycolic acid, and that's the reason the drug isoniazid is only used for tuberculosis, not for any other infections. Then what about adverse effects, sir? I will simplify the adverse effect. Okay, so the name is INH. So I stands for, it's an inhibitor of enzyme. It's an enzyme inhibitor mainly. And also it's a MAO inhibitor. MAO inhibitor. So if you think of isoniazid, it sounds like one more drug, iproniazid. Iproniazid is a MAO inhibitor. We use it in depression. So it's a MAO inhibitor, isoniazid is a MAO inhibitor. N for the drug produces neuropathy. Neuropathy. And the neuropathy is called the peripheral neuropathy. So peripheral neuropathy, the reason is isoniazid interferes with pyridoxine. So pyridoxine becomes pyridoxine 5-phosphate and that is interfered with isoniazid. So patient will have tingling and numbness sensation in the periphery. So if the patient develops peripheral neuropathy, how do we treat it? I told you the problem for that is pyridoxine metabolism is interfered, so give pyridoxine. So pyridoxine is given at a dose of 10 milligram per day. So that can be given. Next, H for the drug produces hepatotoxicity. So the drug is hepatotoxic. Now, what happens if we give the isoniazid at high dose? When we give isoniazid at high dose, there is INH toxicity. INH toxicity. Now there is a triad of INH toxicity. What is a triad? There are three important things we see. One is, in the triad we see metabolic acidosis. We see metabolic acidosis. And that acidosis is not easily treated with sodium bicarbonate. So it is resistant to sodium bicarbonate. So you see that metabolic acidosis. And you see the seizures. Now seizures are resistant to phenytoin and barbiturates. Phenytoin and barbiturates are not going to work. So what is the treatment for the seizures? You have to use the benzodiazepines like lorazepam or diazepam can be used. So metabolic acidosis resistant to treatment with bicarbonate, seizures resistant to treatment with phenytoin and barbiturates, and one more is coma. So this is a triad of isoniazid overdose. Okay, sir, but what is the antidote for INH toxicity? The antidote for INH toxicity, it is by the name pyridoxine. The name is pyridoxine. Now, why, sir, pyridoxine is the antidote? The reason is, when we use pyridoxine, pyridoxine becomes pyridoxine 5-phosphate. Normally, this is the point. Now, when the INH is given, INH will form a complex with pyridoxine and forms INH pyridoxal. It becomes INH pyridoxal. So, the active form of pyridoxine depletes. What happens if it depletes? When this decreases, this will lead to decrease in GABA synthesis. That will decrease the GABA synthesis. Now, what happens if GABA is decreased? You know that in the brain, GABA is inhibitory, glutamate is excitatory. Now, when you decrease GABA, who will go up? Glutamate will go up. So, that will lead to CNS excitation, excitability, and patient will develop seizures. So, the reason for the seizures and the reason for the problem is depletion of pyridoxine, that is active form. So, give pyridoxine as an antidote. So, this is an important question for you. Please mark it. Okay, sir, but how much to give? Pyridoxine is given in the gram to gram basis. Gram to gram basis. That means how much isoniazid has been taken. If you know that, same amount of pyridoxine can be given. Usually it is given intravenous. Now, if we don't know the dose, suppose the patient doesn't know, you can give it in the form of 70 milligram per kg can be given. 70 milligram per kg can be given. If the dose of isoniazid taken is not known, then we can do that. So remember the INH, enzyme inhibitor, MAO inhibitor, neuropathy and hepatotoxicity and INH overdose, the antidote is pyridoxine, and you know what is the reason for that. Now, that is the basic important adverse effect you have to remember. Some of the rare adverse effects what are seen. Some of the rare adverse effect is the drug can, since it's a MAO inhibitor, so what happens if it is a MAO inhibitor? It will increase the serotonin levels. Now, serotonin can cause psychosis and hallucination. So, patients with intake of isoniazid can develop psychosis and hallucinations. It can also increase the activity of noradrenaline because of MAO inhibition. So, patient will have the risk of seizures. So, excitability. So, one of the reason for that is increase in noradrenaline. One more is the seizure reason is decrease in pyridoxine. So, what happens if pyridoxine decreases? There is decrease in GABA synthesis. So, that is also contributing for seizures. So, one of the drug which causes psychosis and seizure is isoniazid. Now, another rare adverse effect is the drug can produce gynecomastia. Gynecomastia, and there is a syndrome called shoulder hand syndrome. Shoulder hand syndrome. So, some of the patients may develop pain and stiffness in the shoulder and the hand. It's like rheumatoid arthritis. It's not rheumatoid arthritis, but the patient will have the symptoms similar to that, and that is what we mean by shoulder hand syndrome seen with isoniazid. So, patient will have pain and stiffness. It's not a common problem, it is a rare problem. Then one more important aspect, patient may develop sideroblastic anemia. Now, this sideroblastic anemia is because of pyridoxine deficiency. This sideroblastic anemia is due to pyridoxine deficiency. So, what should we give? Obviously, we have to give pyridoxine, also called as B6. So, isoniazid induced sideroblastic anemia, the treatment will be B6. Okay, and in some patient, it has caused memory impairment. So, these are some of the rare adverse effects what we see, and seizures you can see with higher doses, psychosis with higher doses. So, gynecomastia, shoulder hand syndrome, then sideroblastic anemia and memory impairment, some of the other rare adverse effects what we see with these drugs. Now, once I know this, what is the specialty? How special it is in tuberculosis? Specialty. The specialty of the drug is it can act on intracellular as well as extracellular bacteria. Extracellular bacteria it is active. Sir, what do you mean by intracellular? Suppose the bacteria is outside, it is extracellular. Suppose it is the macrophage and the bacteria is present inside. The drug has to go inside and kill it. So this is intracellular. If it acts outside the cell, it is called extracellular. That's it. Inside the cell means inside the macrophage. Outside the cell means extracellular. It is effective on both. Second, it is effective on rapidly multiplying bacilli. Effective on rapidly multiplying bacilli. Rapidly multiplying bacilli. And one more, it has maximum CSF penetration. So, which is good in managing the TB meningitis and all those things. It's very easy to manage because it has maximum CSF penetration, and also it is effective in acidic and alkaline pH. So it is also effective in both acidic and alkaline pH. Okay. So specialties are, it can act on intracellular and extracellular bacteria, effective on rapidly multiplying bacilli, maximum CSF penetration. It is effective on acidic and alkaline pH. Sir, why should we do so much extensively about isoniazid? Because one of the prime drug for tuberculosis, that's why the questions will come from that. That's why I had to tell you in detail. One of the prime drug for TB, that's why we should go in detail. And everything has been asked in the exam. That's why I went through detail in this video. The next important drug which we need to understand are for, the name stands for rifampicin. Sometimes in the books it is also written as rifampin. So the drug is called rifampicin. Now rifampicin, what is the mechanism of action? Now this is the DNA. From the DNA we get RNA. So there is an enzyme called DNA dependent RNA synthesis. So there is an enzyme called DNA dependent RNA synthesis. So what is the role of this? To synthesize the RNA, particularly the messenger RNA synthesis. So you know, from messenger RNA we get the protein synthesis, correct? Now if I inhibit this, then the mRNA synthesis doesn't occur, protein synthesis will not occur, the bacteria cannot multiply. So this enzyme is blocked by the drug called rifampicin. Rifampicin. So let us repeat what is the mechanism of action of rifampicin. It inhibits DNA dependent RNA polymerase because of the DNA, the RNA is synthesized from the DNA copy. There is one more thing called RNA dependent RNA polymerase, and that is mainly seen in virus, that is inhibited by a drug called remdesivir and ribavirin. Don't confuse that with this. So that is RNA dependent RNA polymerase. This is DNA dependent RNA polymerase. Now this rifampicin, there was a question recently asked, which of the following drug decreases RNA synthesis? Yes, again the answer will be rifampicin. Rifampicin belongs to a group of drugs called rifamycins. So it belongs to a group called rifamycins. So let me tell you about rifamycins. What are their importance? And also remember, rifampicin is an enzyme inducer. So rifampicin is an enzyme inducer. So with that background, let us start the rifamycins. There are 4 important ones. The rifampicin. Rifampicin is having maximum enzyme induction property, maximum enzyme inducer. Then we have another drug called rifapentin. Rifapentin has the moderate enzyme induction. And one more we have is rifabutin. Rifabutin has minimal enzyme induction. So rifabutin has minimal. So let me also tell you about rifabutin now. Rifampicin I will tell you later, but rifabutin. Now rifabutin has minimal enzyme induction property. So it is used to treat an infection called MAC. MAC stands for Mycobacterium avium complex, and it has minimal enzyme induction. And it has shown to produce uveitis, pseudojaundice, and arthralgia when it is used to treat MAC infection. So this is the adverse effect which is seen when we are using rifabutin to treat MAC infection. This had been asked as a question in one of your recent exams, MCQ. After we know rifabutin, there is one more drug, and that is called rifaximin. Rifaximin, if we give orally also, it is not absorbed. So it has very poor oral absorption. So if it is not at all absorbed, then where is the question of enzyme induction? So no problem, we will not discuss about that. So it will work locally when we give into the intestine. So it is used to treat, one is irritable bowel syndrome, diarrhea predominant cases. So it is used for irritable bowel syndrome, diarrhea predominant conditions. Rifaximin. Second, it is also used in management of pseudomembranous colitis. So these are the uses of rifaximin. Why rifaximin? Because it is not absorbed, it will work locally and kill the bacteria causing diarrhea, and also it will kill the bacteria causing pseudomembranous colitis, that is Clostridium difficile. Okay sir, but one more thing I just want to highlight about rifabutin here. Rifabutin is having better efficacy in MAC infection, that's why it is preferred more than rifampicin, and also it has less enzyme induction. One more important clinical application is, suppose a patient is newly diagnosed with HIV and TB. So he was diagnosed with both HIV and TB. He came to the hospital. When he was checked, he was HIV positive and TB also positive. Now the question number 1, the clinical application. What will you treat first? Will you treat HIV first or TB first? Pause the video and tell me. First, treat TB. First, treat TB. Start the TB treatment. And after 2 weeks, start HIV treatment. So again, this is a repeatedly asked question in your exam. So whenever a patient is having both HIV and TB, what will you treat first? First start TB and then HIV treatment. Now what if you do ulta? If you treat HIV first, if you treat HIV first, what is going to happen is, when you kill the HIV, the immunity will boost up. When the immunity boosts up, there is something called immune reconstitution inflammatory syndrome. There is something called IRIS. So what is that? IRIS stands for immune reconstitution inflammatory syndrome. Now what happens here is, until now what happened, because patient was having HIV, the immunity is not attacking because the immunity is suppressed. Now when you start killing the HIV, the immunity is now started working, and now when it sees the TB bacilli, it mounts the immune response on that. So patient will have fever, lymph node enlargement, all those things, and that is what we mean by IRIS. To avoid that, first kill the opportunistic infection, that is TB. Once the bacilli is cleared, then you can start HIV treatment to avoid IRIS. This is one more question. Second important is, suppose a patient is having HIV and TB. Now if I add rifampicin, the problem is rifampicin is an enzyme inducer. What is the problem? It will induce the metabolism of HIV drugs also. For newly diagnosed patient, instead of rifampicin, what is the best one? Instead of rifampicin, you have to use rifabutin. Why you should use rifabutin? Because rifabutin has less enzyme induction, and if it is less enzyme induction, the drugs used in TB, the drugs used in HIV are not metabolized, and they will not become short acting, and there will be no drug failure. So a newly diagnosed patient with HIV and TB, so instead of rifampicin, use rifabutin. Very important. So much applications are there here. Now one more implications of rifampicin is a drug interaction. What is that? Let me tell you this. One more case history. Rifampicin is an enzyme inducer. Suppose a lady is on oral contraceptive pill. She is taking OCPs, she is married, and now recently she has been diagnosed with tuberculosis. Now the question is, what is your advice to her? She is on OCPs, she is married, and she is being diagnosed with tuberculosis. What is your advice to her? The advice to her is, we have to start treatment for tuberculosis, and a major drug for TB is rifampicin. Now rifampicin is an enzyme inducer. If I use this, the OCPs will be metabolized faster and there will be contraceptive failure. So this will lead to contraceptive failure. So the contraception will not work and she will become pregnant, and she is already having TB. Usually we don't want a patient with TB to become pregnant. We try to avoid that. But if she becomes pregnant, again the drugs are toxic, it will affect the fetus. We don't want to take the risk. So tell her to use alternative method of contraception like barrier method or condoms. So this is the advice you can give. She is already in OCPs, you put her on rifampicin, there is a risk of contraceptive failure, tell her to use a barrier method of contraception. Again, this is application question they can ask you. So we understood the mechanism of action, we understood the various aspects of rifamycins. I told you there are 4 different types of rifamycin: rifampicin, rifabutin, rifapentin, and rifaximin. And what are the important clinical applications of this? Right? So once we know it, let me come back to the TB drug. Rifampicin, it's a pharmacokinetically, it's an enzyme inducer. So it will induce the enzymes. Second, it undergoes enterohepatic recycling. So it undergoes bile elimination. So if it undergoes bile elimination, is it safe in renal failure? Obviously, it is safe in renal failure. Yeah. Now, where do you use this drug? Where do you use it? Major use of this drug is in tuberculosis and in leprosy in our country. So we should keep this drug only for TB and leprosy. We cannot use it for routine treatment. So that is the major uses. The other uses are, it is also effective in other conditions. What is that? It is useful in managing MRSA. It is also used in meningococcal prophylaxis. Meningococcal prophylaxis. Sir, do we use it in prophylaxis of meningococcal? Yes, but we try to avoid using that drug because if I start giving that to everyone, it will acquire resistance and you cannot treat TB. So the best drug for meningococcal prophylaxis is ceftriaxone. It is also used in managing H. influenza. Then brucellosis. Brucellosis management is like this. So along with doxy, we add rifampicin. And also Legionella. Sir, you told isoniazid is only used for TB, but why are we using rifampicin in other bacterial infection? Because every bacteria has DNA and they want to produce RNA. So if I inhibit that, you can inhibit any bacteria. So that's why it is also useful in management of leprosy, MRSA, meningococcal, H. influenza, brucella, all those things. Okay, sir, we understood. What is the adverse effect? Any problem? Now remember, when you think of rifampicin, think of the letter R. So it will cause orange red discoloration of secretions. So you remember R for red discoloration. So which type of R is it? It is called orange red discoloration of secretions. So what secretions can become colored? Urine, saliva, sweat, even tears. Even people wearing contact lens, the contact lens will get colored with that. Second, the drug can also produce hepatotoxicity. And another important aspect, it causes certain syndromes. So syndromes such as cutaneous syndrome, then flu syndrome, then abdominal syndrome. Now these syndromes are like nothing but symptoms. Flu means cough, cold, like that. These syndromes usually occur when you are giving rifampicin intermittently. So this is seen when you are giving the rifampicin intermittent dosing. Intermittent dosing. Nowadays we are not using it intermittently, we are giving the drug daily, so these syndromes are not seen. But what you should majorly remember is orange discoloration of secretion, even the contact lens, urine, sweat, saliva, that is a major adverse effect you have to keep in mind for rifampicin. Keep another point for rifampicin, it's an enzyme inducer. Very, very important. Now the specialty of rifampicin is, it can also act on intra and extracellular bacteria. It is very good for something called spurters or something called persisters. It is effective, right? So these are the specialties of the drug rifampicin. And remember, when we add H and R, they are known to produce synergism. So the action of isoniazid and rifampicin is an example for synergistic action to kill the TB bacilli. Very, very important. So please remember, the first two drugs in TB are very, very important. I have told them in detail. Very, very important. Then Z stands for a drug called pyrazinamide. The name is called pyrazinamide. So pyrazinamide, when it enters the bacteria, in the bacteria there is an enzyme called pyrazinamidase. This is coded by a gene called PNCA gene. PNCA gene, it is coded by this. So that will give rise to an acid called pyrazonic acid. Now the mechanism of pyrazinamide is not well understood. So whatever the mechanism is given for that is, there are two important things they can do. They inhibit a fatty acid synthase. Fatty acid synthase. And that fatty acid synthase is required for cell wall. So penultimately it inhibits cell wall synthesis. Cell wall synthesis, that is pyrazinamide. Now another mechanism proposed is this pyrazonic acid can disrupt. It can disrupt cell membrane of the bacteria. Not only that, it also disrupts the transport mechanism. And transport mechanism, this is being proposed for pyrazinamide. So not so much important mechanism of action, because usually it is unknown, but whatever is proposed I have told you. So penultimately remember, it also inhibits cell wall synthesis. It requires an activation by the enzyme pyrazinamidase. And if the bacteria has to become resistant to this, it has to produce the mutation in PNCA gene. If it is mutated, the enzyme is not produced. If the enzyme is not produced, pyrazinamide will not become active. So simple. Now what are the specialties of this? What are the specialties of this? Now this pyrazinamide is effective in acidic pH. It is very much effective at acidic pH, and it is effective on intracellular. Why intracellular? Because intracellular, inside the macrophages, the pH is acidic. So it is very good for intracellular bacteria, and it is very good in inflammatory areas. So wherever there is inflammation, it is very effective. Very effective. Why? Inflammatory means acidic pH, so it is very effective at that. One more is, why we are adding pyrazinamide for the TB treatment? We usually give H, R, Z and E. So what is the advantage of adding Z to that? Pyrazinamide will decrease the duration. Usually the TB treatment was for 9 months. So when we added pyrazinamide, the duration now is for 6 months. So it reduced the treatment duration from 6 months, from 9 months to 6 months. And also it has very good sterilizing property. Very good sterilizing property, that is pyrazinamide for it. Okay, so pyrazinamide. What is the adverse effect? The adverse effect is, you remember pyrazinamide starts with P. So adverse effect is pain. Now what pain? Pain in the joint, arthralgia. Now why arthralgia? Why pain in the joint? Because it increases uric acid. So patient will have hyperuricemia. So the drug can produce hyperuricemia, so that will lead to joint pain. Should we stop the drug if the patient develops joint pain? No need. Just give NSAIDs, that's it. Second, it is one of the most hepatotoxic drug. Hepatotoxicity is very common with this. So most hepatotoxic among the first line drugs. Most hepatotoxic. So we understood pyrazinamide. Remember, pyrazinamide inhibits cell wall synthesis. The gene is called PNCA gene. Very good for acidic pH inside the bacteria. Inside the cell, it is very good. Addition of pyrazinamide has reduced the duration from 9 to 6 months. It has very good sterilizing property. And adverse effect, remember P for pain, and most hepatotoxic drug. Then E for the drug ethambutol. The name is ethambutol. Now all the 3 drugs what we discussed are all cidal, but only drug which is static in first line is ethambutol. Very, very important. Now ethambutol, what is the mechanism of action? It inhibits an enzyme called arabinosyl transferase. Arabinosyl transferase. Now if we inhibit that, there is inhibition of arabinogalactan synthesis. There is inhibition of arabinogalactan synthesis. Now this is important for forming the cell wall, so that will inhibit cell wall synthesis. You may ask a question, sir, even though it inhibits cell wall, yes, there is some exception. Even though it is inhibiting cell wall, it is a static drug. I told you same thing in when we discussed the cell wall synthesis inhibitors, all are cidal. Usually the drugs acting on cell wall are cidal. Exception is one, cycloserine. It's a tuberculostatic even though it acts on the cell wall. So we understood. Now this enzyme is coded by a gene called MB or MA gene. So even this is responsible for resistance here. Now what is the adverse effect? What is the adverse effect? Remember, when you think of ethambutol, start with IE. So it causes eye toxicity. It causes eye toxicity. So what is the problem here? Retrobulbar optic neuritis. Patient will have retrobulbar optic neuritis. What will happen with that? The blindness occurs. What is that? Red, green blindness. So recently the question had been asked, which drug used in tuberculosis can cause red, green blindness? Not only that, it decreases visual acuity. Visual acuity, that is the ethambutol for eye toxicity. And it can also mild increase in uric acid. Not too much, mild increase. Now where do you use it? It is used in treatment of tuberculosis as well as in the treatment of MAC infection, Mycobacterium avium complex. Mycobacterium avium complex. So we are done with the first 4 drugs, importantly HRZD. The last important one, streptomycin, which is called as supplementary drug. We have discussed about these drugs in aminoglycoside. Just I will tell you the main important aspect. It's an aminoglycoside drug. It is effective as a bactericidal drug and you should never give that in pregnancy. Contraindicated in pregnancy. And because why it is contraindicated in pregnancy? Because aminoglycosides are ototoxic, they are nephrotoxic, they can cause neuromuscular blockade. And remember, these streptomycin are very effective in alkaline pH and they are effective on extracellular bacilli. Extracellular bacilli. And since these are not absorbed orally, this is given as injection. So that's the reason it is not a first line drug, it is a first line supplementary drug. So that is about the first line drugs HRZDS. So once we know the first line drug, let us summarize everything in a single slide. So the first one is what drugs are there? The first line drug HRZDS, which are cidal here. H, R, Z and S are cidal. The only static drug is ethambutol. Now what drugs are going to act on intra and extracellular? H will act on both. This will act on both. And pyrazinamide is going to act on the intracellular bacteria and it is very much effective at acidic pH. Now ethambutol is mainly also which can act on both. Now this one is extracellular and effective in alkaline pH. That is streptomycin. Now which is most hepatotoxic? Pyrazinamide is most hepatotoxic, medium is isoniazid, least is rifampicin. The last 2 drugs will not produce. Now where do you want to reduce the dose in renal failure? The first 2 drugs they don't require because they are undergoing bile elimination. Pyrazinamide mild, ethambutol yes, and streptomycin obviously 100% yes. Pregnancy you can use these 2 drugs. Pyrazinamide try to avoid it. Ethambutol yes, you can use it, but absolutely contraindicated aminoglycoside. This is a commonly asked question in exam. In TB, which group of drugs are absolutely contraindicated? Aminoglycoside because they cause ototoxicity. So absolutely not used. Now moving on to the gene mutation. This is the major mutation is CADG gene. The minor mutation is seen with the INHA gene and the CAS-A gene. Rifampicin it is called as RPOB gene. For pyrazinamide it is called PNCA gene. For ethambutol it is called as MB and A gene. For streptomycin it is called as RPSL gene. So you can read the name itself. Rifampicin start with R, pyrazinamide P, ethambutol M. So only thing you have to remember is the streptomycin and CAT-G genes. So recently they asked a question, what happens if there is CAT-G gene mutation? The catalase peroxidase is not produced, so the INH will not become active. So once we know that, let us understand which drugs are more effective in fast multiplying bacilli. For fast multiplying bacilli, the drug is most effective for that is the INH, that is isoniazid. For slow multiplying, it is the pyrazinamide. Slow and intermittent dividing, that is persister or spurters, it is rifampicin. Dormant bacilli. Dormant means it will not multiply, it will sleep. No drug till today is not effective for that, because you know that once the bacteria multiply, then only you can kill that. But if it is sleeping, nobody can do anything. So till now there is only one drug effective for that, and the name is called bedaquiline. We'll discuss that drug later. The name is called bedaquiline. Now where do you see fast multiplying bacilli? You see them in walls of cavitary lesions. You see them in walls of cavitary lesion. Where do you see the slow multiplying bacilli? You see them in inflammatory site. Inflammatory site or inside the macrophages. And persister spurters, they are seen in caseous material. Now what happens in the walls of cavitary lesions? In the walls of cavitary lesion, the oxygen tension is high oxygen tension, and the pH inside that is neutral pH. Now you know that inflammatory site macrophages, obviously the pH is acidic pH, and also the oxygen levels will be low oxygen. Now caseous material, the pH is neutral, but the oxygen tension is low. So these are situations where the drug should go and work, and that's why I told you why we are giving them together. So what is the rationale for combining HRZD S together? So the H and R, why do we add? They have synergistic effect. They have synergistic effect. Why are we adding the Z? Z has decreased the duration of treatment from 9 months to 6 months. And also it has very good sterilizing property. Sterilizing property. Then why are we adding ethambutol? Ethambutol has known to decrease the resistance problem. So that's the reason in drug sensitive tuberculosis we use the 4 drugs as combination. And the logic is, suppose there are around 10 to the power of 8 bacteria. So in that, one bacteria may get mutated, and that will proliferate more and more. That will multiply. If you don't kill that, there is a high chance that that becomes resistant. So if we combine 2 drugs, that which get mutated can be killed by other drug. So that's the rationale why we combine drugs in treating tuberculosis. So once we have understood the first line drug, let us understand second line drug. Sir, why should we require a second line drug? Because the first line drug may acquire resistance and we should have some reserve. And that's the reason why we have the second line drugs. So we have the second line drugs. So what are the second line drugs we use in the treatment of tuberculosis? So let me tell you that. So the first category, they are called as fluoroquinolones. Fluoroquinolones. In that, 2 major drugs what we are using is, one is called moxifloxacin and one more is levofloxacin. So very, very effective drug for TB. But when you are using moxifloxacin, watch out for a problem called QT prolongation. So there is a risk of QT prolongation with moxifloxacin. Previously, there was use of ofloxacin and ciproflox, but these are less effective for TB. These are less effective for tuberculosis. So for TB now what we are using is the moxi and levo, very, very common. The second category of drugs what we are using are injectables. So we also call them as second line injectables. Because we give them as injections, we cannot give them orally. What are these second line injectables? You can remember as ACK drugs. So what is that ACK drugs? ACK drugs are the amino glucoside like amikacin. C is for capreomycin and K for kanamycin. So streptomycin is also used in TB, but it is a supplementary drug. You can remember as SAC. S for streptomycin, but it is supplementary. A for amikacin, C for capreomycin, K for kanamycin. They are all injectable drugs. You cannot give them orally. Now the third drug is by the name thioacetazone. So thioacetazone was one of the earlier drug for tuberculosis. The drug is tuberculostatic, and a major drawback of the drug is hepatotoxic. And advantage why it is used, because it has low cost and it has shown to decrease the resistance problem. So it has shown to decrease the resistance problem, and that's the reason it is still being used in certain places. So the fourth drug is called as cycloserine, and this drug is known to inhibit cell wall synthesis, but it is not a cidal drug. Cycloserine is a static drug. And as the name suggests, cycloserine, you can call it as psych-serine. So the adverse effect of the drug is two important things. It can cause psychosis and patient may develop seizures. So that's why it is also called as psych-serine or cycloserine. Now the derivative of this, similar to this, we have a drug called terizodone. It is called as terizodone. It is made up of two molecules of cycloserine. It is made up of two molecules of cycloserine. The name is terizodone. So what is the advantage? It has less neuropsychiatric adverse effect. That is very less with this. That is one advantage. Second, it is preferred in genitourinary TB. Genitourinary TB, this is preferred, that is terizodone. It is nothing but it is made up of two molecules of cycloserine, and it has less neuropsychiatric adverse effect, preferably used in genitourinary TB. Next, fifth one. Now this drug is called ethionamide. The name is called ethionamide. Ethionamide has shown to produce cross resistance with INH. It has cross resistance with the drug INH, isoniazid. So similar to this one, we have one more drug that is called prothionamide. And these two drugs also inhibit cell wall synthesis, similar to isoniazid. So they inhibit cell wall synthesis, and they have cross resistance with isoniazid. Now the sixth drug is called PAS. Now PAS stands for para-aminosalicylate. Let me tell you that. Para-aminosalicylate. Now this drug, you have studied that in sulfonamide. It inhibits the enzyme. What enzyme? It inhibits the dihydrotyrosine synthase, that is folic acid synthase. Now this is one of the first drug to be discovered for tuberculosis, that is PAS. Then came streptomycin, then came thioacetazone. So this is one of the first drug for TB. The problem with these two drugs, ethionamide, PAS, the adverse effect with both of them is patient may develop hypothyroidism. So one of the adverse effects with these drugs are hypothyroidism. Ethionamide and PAS can produce that. The next drug, we have a drug by the name linezolid. We have discussed that drug separately in the video, and it is used only for drug resistant tuberculosis. Now, eighth, we have drugs with unknown efficacy. So the efficacy is unknown, but since we have resistant problem, we are using them. What are those? Examples are combination of imipenem plus cilastatin. Then we use a combination of amoxicillin plus clavulanic acid, and we are using meropenem. We don't know the efficacy, but we are trying them in resistant cases. Ninth, we also nowadays are trying a drug for leprosy. Can you guess what is the drug for leprosy also used in TB? Yes, you are right. It is called as clofazimine. So that is also being tried in drug resistant tuberculosis. So these are the second line drugs. Let me repeat them again. So number one, fluoroquinolones, then aminoglycosides, thiazidazone, cycloserine, ethionamide, PAS, linezolide, and clofazimine. These are all second line drugs. So let me ask you a question, are there any newer drugs for tuberculosis? Yes, we have newer drugs for tuberculosis. And the newer drug is called bedaquiline. What is the mechanism of action of bedaquiline? Mechanism of action is it inhibits mycobacterial ATP synthesis. So you know that ATP is required for energy process. If I don't give energy, the bacteria will not survive. Now I told you it's very difficult to kill a dormant bacilli. Why? Because it's not multiplying. But if I stop the energy only, even the dormant bacilli can be killed. So one of the only anti-TB drug effective on dormant bacilli is bedaquiline. Yes. So the specialty is it can work on dormant bacilli. It can act on dormant bacilli and it is a bactericidal drug. So the name is bedaquiline. But when you see the pharmacokinetics, you will be stunned because it has a very long half-life, around 160 to 165 days. So the drug will remain very long. The reason why it remains very long is the drug is having high volume of distribution. So 160 to 165 days means almost 5 to 5.5 months the drug will be there. Half-life itself is that much. Then the drug, when you take it with food, absorption increases. So fatty food or a heavy meal, fatty food increases drug absorption. Yes. Then the drug is metabolized by the cytochrome enzyme. So there is a drug interaction. So when you combine, you should be very careful. Metabolized by the enzyme cytochrome 3A4-5. Is there any adverse effect? Yes. The drug has some adverse effect. One is it can cause QT prolongation. And since we are using it for a very long period, there is a risk of hepatotoxicity. Now, this drug doesn't have any cross resistance with any anti-TB drug. But recently there are reports it has cross resistance with clofazimine. Now, since the drug is very long acting and causes QT prolongation, the drug is approved for limited period only. It is not used for a very long period. If you are using it, it is only for 24 weeks. So if you are using bedaquiline, it is approved for very short period. How it is given? It is given like this: 0 to 2 weeks. You have to give the dose of 400 milligram daily. From the third week up to 24 weeks, around 6 months, you have to give it 200 milligram, not daily, here changes. It is thrice weekly. So total dose in a week should be around 600 milligram. So total dose in a week should be 600 milligrams. So we give 200 in a week. So It is approved for only 24 weeks, not very long. The another specialty is the drug is used and approved only for drug resistant tuberculosis. Which tuberculosis? Drug resistant pulmonary tuberculosis only. Not for extrapulmonary. Remember, not for drug sensitive TB and not for extrapulmonary TB. So that is a specialty of bedaquiline, very, very important. Now there is a regimen that is being used to treat TB, that is called the BPAL regimen. It is called a BPAL regimen. So what is that BPAL regimen for? B for bedaquiline, P for pretomanid, and L for linezolid. So these BPAL regimen, all the drugs are given oral and they have very less toxicity. So this is being approved for MDR TB as well as extensive drug resistant TB. So these are used. So the advantage is all are oral and safety is more. But when you are using bedaquiline, make sure that bedaquiline should not be used for more than 6 months. That is the only thing. Now you may ask a question, sir, is bedaquiline safe in pregnancy? No, you should not use bedaquiline in pregnant women. Very, very important. So sir, what is pretomanid? You didn't tell. Let me tell you that now. Pretomanid, it belongs to a group called nitroimidazoles. Nitroimidazoles, they are called as bicyclic nitroimidazoles. Bicyclic nitroimidazole. Now this is the second newer drug what we have for TB. Now the examples for this is pretomanid and one more is delamanid. Sir, what is their mechanism of action? They also inhibit the protein and they also inhibit the mycolic acid synthesis. So they inhibit the protein and mycolic acid which are required for cell wall. So penultimately they also inhibit cell wall synthesis. So pretomanid, delamanid, they inhibit the protein as well as mycolic acid required for cell wall synthesis. The only problem what has been noted is they can cause QT prolongation. And remember, similar to bedaquiline, pretomanid, delamanid should be used for mainly the drug resistant tuberculosis, not for drug sensitive TB. And they are also approved for pulmonary TB, which is drug resistant TB. Don't give it in drug sensitive TB. So these are very, very important drugs for us. So we have to preserve them. And that's why the question comes. Right? So these are bicyclic nitroimidazole group of drugs. So until now, we have discussed drugs used in tuberculosis. And there are two important categories, the first line and second line drugs. So the first line drugs are HRZDS and the second line drugs are fluoroquinolones, then injectables, that is aminoglycosides, then we have linezolid, cycloserine, then we have thiazidazone, then we have ethanamide, prothionamide, PAS, and then an anti-leprosy drug that is clofazimine, unknown efficacy drugs like imipenem, cilastatin, then meropenem, then amoxicillin clavulanic acid. The newer drugs are bedaquiline, which inhibits mycobacterial ATP synthesis. You should know that in detail. Then the new drug pretomanid and delamanid. Now first line drug, remember isoniazid mechanism of action, it inhibits mycolic acid synthesis. Two problem, hepatotoxicity and peripheral neuropathy, give pyridoxine. Rifampicin inhibits DNA dependent RNA polymerase. Start with R, it can cause orange red discoloration of secretions. Pyrazinamide inhibits the cell wall synthesis. Remember P for pain. So why pain? Joint pain. Why? Because of increase in uric acid and it is the most hepatotoxic drug. Ethambutol inhibits arabinogalactone synthesis. It also inhibits cell wall synthesis. Even though it inhibits cell wall synthesis, it is static drug. And what is the adverse effect? Eye. It can cause retinal blindness and decrease the visual acuity. So this is in brief what we have discussed in anti-TB drug. And these are the things which you keep in your mind, and please focus on first line drugs. The management of TB and what are the regimens we use it will be discussed in separate video. Thank you all. That is about anti-TB drugs. Thank you.